Okay, thank you. So welcome again after a bit long time, after a week. So there is a big pause. So we have completed the normal topographic and anatomy of medulla oblongata, and we have little bit briefly went through some safe entry zones to the medulla oblongata. So I was saying that this is the tactography. It's very important because a lot of tracts are there. So we should know that where the lesion is actually localized. If the lesion is between the tracts, where will be our trajectory and what will be the trajectory so that we shouldn't disturb the tracts. So look at here, this is the tactography. It's showing the corticospinal tract, a ring enhancing lesion just lateral to it. This lesion causing the displacement of this tract. So when we go ipsilateral to this lesion, it will be very easy to target this lesion. And these are all three, these are DTI, or you can say the tactography. On the left side here, patient is on the operation theater table, and the position has been done. We have gone through the monitoring, neuromonitoring of the lower ciliary nerves, and that is very easy. And same side, we also gone for the brainstem monitoring as well. That is called the BERA or ABR. So the downward last one, what is this? Which Yukan is this one? Anyone? Anyone who can interpret? Yes, please.
Fiesta MRI.
Yes, excellent. This is Fiesta MRI and this is the nerve. It's very clear because it's showing that this tumor it is adherent to the nerve. So these are very important. We should know the Fiesta if available. We should go on through the Fiesta MRI. We should go through the neuromonitoring, and if there is a DTI is available, tactography is available, we should avail this opportunity because it helps a lot while doing in the preoperative trajectory. So approaches to medulla oblongata, it depends on that what is the lesion and where is the lesion actually. There are three types of the lesions most likely, mostly typically anteriorly placed lesions at the anterior side, posterior side lesions to posteriorly, and anterior lateral or posterior lateral, it is the same territory. If there is anterior laterally placed or the posterior laterally placed. So there are three types of lesions, and we divide these approaches according to that. Where the lesion is there, we will opt that approach. For posterior lesions, midline suboccipital approach is a very standard approach and explores a lot of approaches when we go through this suboccipital approach. For lateral transcondylar approach, for anterolateral lesions, the excellent approach, it helps a lot also when there is extended or the huge lesion is there, anterolateral or the posterolateral, then it helps a lot. Transpetrosal approach, anterolateral lesion is there, we can again avail this standard approach through the help of the temporal and the anterior petrosectomy. Then we can go through and approach the anterolateral lesions. And also the most standard approach for the petroclival region, just top of the medulla oblongata is there and anterior place lesion is there. So anterior petrosectomy helps a lot while addressing the lesions. Retrostigmate approach, laterally placed huge and large lesion, we can approach this one. Endoscopic transnasal transclival approach. This is most of the time is not being used. It's a safe approach. Just we can take, but limited corridor is there. That's why it's not being used most of the time. But it's a very excellent approach. Suppose that at the level of clivus medulla oblongata anteriorly place lesion is there, we can approach easily by attacking some kind of a tumor. Though because of this approach, you cannot get the whole tumor, but maximum exophytic component can be approached through this one. Before going to this, the trajectory and how we have to go through the position, While when we talk about the indication of these all kind of approaches to the medulla oblongata, it's quite easy because the most of the time the brainstem lesions, they are very difficult to approach. Usually we resect the exophytic component of the glioma if the glioma is there, or any extra axial lesion is placed, and just compressing the brainstem we can get it. We can resect the whole tumor. And another, the cavernomas, brainstem cavernomas can easily approached in a very good manner and excised completely while according to the placement and site of the lesion through these all kind of approaches. So these are little bit indications of this one, but lot of approaches are there which are standard approaches. So like the midline suboccipital approach, when you go through the midline, it doesn't means that only we are approaching the medulla. Because of this post, you also can go through the transvelar telovelar approach to the fourth ventricle and above to the you can say the bone. So these are the some standard approaches are there. When we talk about the position, it's very important in the posterior fossa because due to positions, most of the time, and some of the because of this one, it has some hurdles, creates some hurdles by approaching the tumor due to position. Look at here, the superior one is the neutral position. Most of the time, we keep the patient in prone position, but when it is a neutral, it obscures your vision towards the whole brain stem and the normal pathways of the lesions and tracts as well. The above one, this one, look at here. This is the neutral position of the patient. When you are going through this one superiorly, you only target it to that point vertically, but not going through all the way. But when there is a military position, we call it the military position. That means the flexion plus chin tuck should be there. There should be the two finger brace just distance between the chin and sternum. Otherwise, it should be flexed. When you flex the neck of the patient, look at here. When you are going through here from the foramen magnum till that whole, most of the brain stem you can visualize as much as you can. Fourth ventricle can be visualized in cerebellum, and it helps the retraction as well. So that's why this military position, or you can say the head flexion, is very important when someone is going through this approach. Midline suboccipital approach. This is the position and bit flexion. This is not the ideal one. The flexion will be most, again, more one as compared to this figure because it slips. When we say the position and extension, it will be the straight prone position. The head should be tilted downward, flexed, and the back and the posterior side of this one will be 30 to 20-degree elevated. It helps a lot while during this vision. We start the incision from the ania until that C2. The skin incision could be here, but our intraoperative exploration will be minimum as compared to this one. This is the standard incision. We will give vertical incision to this one. This is very important to know the surface anatomy of this one. Though the incision is from here till that here, it looks a large incision, but this is the three dynamic picture. That's why it looks long. From here to here, this is incision. From NEN to C2. But look at here. This is what you can say this is the ridge of the transverse sinus. When we see internally from this one, it has some sulcus type, depression type ridge there, in which the transverse sinus lodges. But actually, our craniotomy will be here. Actually, the target is here. This is here over this is not the target. Actually, the target is here. So that's why it's very important to know. Before going to this one, when we are talking about the skin incision, we should know each and everything regarding the skin incision and what are the normal structure and what structure should be avoided. So when we are going through this, giving the skin incisions, what we should be care of, what structures, what is the possibility that what structures could be damaged here? That is important. Those are important. Anyone, please? Yes, just the skin incision. We are cutting the skin. You are cutting the fascia, not the muscles. So what kind of structures you can damage till that muscles? Yes, please, anyone? Excellent. Someone says occipital artery is so very important. Lower one is very important. Occipital arteries and greater occipital nerve could be damaged. So one should be careful and while doing the dissection of this one. When we are going, we have completed the skin, the linear incision, it will be parted laterally, bilaterally. When we go through this one, we have to know there will be soft tissue dissection is there. It could be muscular and the fascia. This is the muscle fascia. Apart from this one, external occipital protuberance. This is incision line, midline is called the linea alba. And when we say these are the four muscles are there. That is the mastoid muscles as well, and the trapezius. But these are the four muscles that should be we should know. Rectus capitis major muscle, rectus capitis minor muscle, scalenus capitis muscle, scalenus capitis major muscles. These are the four muscles that should be dissected. We have to dissect it and retract laterally. It's very important, or not below one, because when we retract these one lower one, it will create the hurdles while opening the posterior fossa while doing the craniotomy. So it's very important to know. So after the muscle dissection and soft tissue dissection, there is a craniotomy and craniectomy. Some neurosurgeons do the craniotomy and some neurosurgeons do the craniectomy. But to me, I prefer the craniotomy, not the craniectomy. If you feel that intraoperatively or postoperatively while doing the edema is there, you can remove the bone. But when you say you have done a quite good job and there is no any chances of intraoperative the post-operative, you can say the edema, and there is no any hemorrhage, so you can place the bone in a good way. That's good, I think so. So these are the placement of the four bulbs, and you can say the transverse sinus, and just 1.5 centimeter lateral to the midline, and next two bulbs, the lower bulbs, you can place
Your voice is breaking again.
the 3.5 centimeter, 3 to 3.5 to the above bulb are connected. Now
Your
it's clear?
pizzas? Yeah, you need to repeat the craniotomy. Your voice was breaking. It was not
Now,
audible. Yeah, it's audible now.
now it's clear.
Yeah, it's clear, but you would need to repeat the craniotomy and the burhole
So I
placements.
said that we usually place the four burr holes, two at the top and two at the lower one. The top burrs, that are two burr holes, just 1.5 centimeter lateral to the midline. And the second thing is that just below to the transverse sinus. And the lower burrs, that is the lower to the above one, these are 3 centimeter to 3.5 centimeter below to the above burrs and just lateral to 1 to 1.5 centimeter lateral. So when we say the above side, the craniotomy will be small, and the lower side, the craniotomy will be big, like this shape. Okay, and this is the reason why. Because when most of the time, usually we need the lower exposure more as compared to the above one. That's why we are we are creating the more wider craniotomy at the lower side as compared to the above one. So usually we need the 3 to 4 centimeter craniotomy, but not more than this. Why? Why not more than 4 centimeter? Yes, please. Anyone? Cerebral said, very excellent. So after this one, there will be the dura. We have done the craniotomy. We should know that the dural opening should be there, and we should know some structures. Is occipital bone, external occipital protuberance. This is the carotid, just the junction of this one, vertebral junction. This is the C1 arch. And this is the occipital sinus. Most of usually we do the Y-shaped craniotomy, 2 limbs on the lateral side and 1 limb on the mid of this one. What um, I did some limited cases, but I do not. I combine this one. I do just suppose that most of the tumor is this side. I draw and size a durotomy here, but I will tilt that like this one. Okay, and same. I cut this dura and bilaterally I cut it. It help a lot. It helps. It most of the time, usually we cannot hurt the occipital sinus. When we will meet these 2 lines are here and we are cutting it, most of the time it will causing the damage to the occipital sinus. Usually we do ligate this one, but it will be easy when bilaterally we are going downward, then we are ligating because dura will come out upper side. There will be no any tension over the dura. Then we will easily cut down and ligate and then cut down the dura. So this is the dural opening of this one. This is the picture. We should know it is a good opening of the dura. This dura has been opened. Yes, please. It is the right opening of the dura. Durotomy is okay, right or no? Yes, please. Yes, very wide, Dr. Kamali. You are right. It's very wide. Whole bilaterally cerebellar, who it is not right. What is right? The right is that if someone has the not idea, so the half size of the cerebral hemispheres should be visualized, not more than this. So this is the complete visualization of hemisphere of the cerebellum, but ideally it should be here. So remember the rule of half. Half cerebral hemispheres should be visualized, not more than this. So when we will do the half gyrotomy, then it will be same 3 to 4 centimeter. When we were opening the dura, so before going to this one, I will go to this picture. When you are going to the opening dura, after the opening of the dura, it's very important for the neurosurgeon to have the imagination of the posterior fossa anatomy, normal anatomy that we have gone through in detail previously. That what structures, suppose that this is the medulla oblongata, lower part of the medulla oblongata, and just above, the bit above part. So when we are targeting this area, we should know in our mind that what is the image of intraoperative could be here. So look at here, versus very easy to get access to the lower part of the medulla oblongata because laterally there are nerves, laterally there are vertebral arteries. Just posterior side there is some venous plexus. Just posterior side there will be venous plexus. So So that's why we should know that when we are going through the medulla oblongata, it will be quite easy for us to go posteriorly or anteriorly. So when we are doing this, it's easy and it's very important that you should know the normal anatomy of the approach. If you are going posterior anteriorly, yes, this is anterior view. You are right, Dr. Kamal. So this is the view. When we are going through this one, so you should memorize, you should think about the posterior part of the, you can say the normal anatomy of this one after opening the dura, because when we have the clear image in our mind, then it is very easy for us to memorize this one. When we are going through the posterior part, cerebellar has a lot of surfaces, three surfaces are there, the tentorial, the occipital, and the CP approaches of there. So this is the suboccipital surface of the cerebellum. When we visualize, you will visualize the suboccipital surface and the tonsils. Tonsils are very important, and the landmarks are there. Below to the tonsils, we are addressing, you can say, some lower part of the medulla oblongata. This is the part of the obex, and above this one, there will be the superior part of medulla oblongata. These are two vertebral arteries at the level of C1. These are entering, and this is pica. Pica is at the level when we start at the top superior part of the medulla oblongata, there will be pica. When we are addressing the lower part of the medulla oblongata, we cannot find the pica usually most of the time. We find the pica when we are going above part of the medulla oblongata, or we are going to the Telovelar approach to addressing the upper part of the medulla oblongata. This is the vertebral arteries. Most of the time, in the posterior part of the medulla oblongata, you will be not find any structure. This is safe zone. That's why we call it, this is the safe zone here. Laterally, there will be, you can say, the nerves. Otherwise, there will be no any structure at all. So after the durotomy, dura has been done. We have opened the dura. Now there will be the visualization of, you can see there is the arachnoid is there. How you will open the arachnoid? Anyone please? How will you open this arachnoid? This is the case. How will you open the arachnoid? So how will you open the arachnoid? There is a rule. Don't pull, peel it. Usually, if someone is pulling the arachnoid membrane, if someone is coagulating or not coagulating, I will say someone is burning the arachnoid, that will be very danger, and the surgeon will be also in danger, and the patient will be in the danger situation as well. So don't burn the arachnoid, or don't coagulate the arachnoid. Try to peel it. Try to just, yes, fine needle. Just fine needle, big little bit a hole, then fine with the help of fine needle or the scissors, micro scissors, you can open it, and little bit quite easily and humbly you can dissect it. So this is very important. You have to, this, someone has pulled this one, so this is very dangerous. So peel the arachnoid. When you will peel it, it will give you the normal opening, and as well as give the sides where you are opening this one. It will be quite easy for you. So we have opened this arachnoid. This one here is the pica superiorly when you are going through this one. So am I right? Am I wrong? Am I describing it in a right way or wrong way? Yes, please. This is which view? Anyone?
Sir, upward is downward and downward is upward.
Yes, good. You have picked that. So the surgeon is standing on the head side. Okay. The surgeon, when surgeon is standing on head side, this is the view of head size. When surgeon is standing the posteriorly, not behind to the patient, not the head size, you will see that the cerebellum is above and the medulla oblongata is below. So you are right. So this is cerebellum and here is the medulla oblongata downward. So it is very important. Some surgeons prefer to stand on the this is the medulla oblongata. This okay. At the superior side, at the head side, that's why is addressing like that. So this is the quite right view. We are standing at the patient side, on the posterior side, not on the head side. That's why the cerebellum is above side and the medulla oblongata is lower side. Okay, so now look at here. We have peeled the arachnoid. When we peel the arachnoid, it is very good picture of the structures posteriorly. This is cerebellum, cerebellar tonsils. Okay, this is medulla oblongata. Okay. So when you are going through this one, now we have to know that what corridor we are using. If there is a lesion at the lower side of this one, previously we have discussed that we have three safe entry zones to the medulla oblongata. One entry zone, that is anyone who can repeat that entry zones?
Yes, sir. Sir, through the anterior lateral sulcus to caudal to the hypoglossal nerve nuclei, or the other one is through the inferior olive, most prominent part of the inferior olive, and from the posterior median sulcus, sir.
Any other one?
No, sir.
Any other one? There are two safe entry zones you have told. One is the anterolateral sulcus, ALS, and second is the transolivary sulcus through the help of the transolive, and third one?
Posterior median sulcus, sir.
Posterior median sulcus and the anterior median sulcus. Okay, so good, thank you. When you are doing this one, it's quite important for us because the lower medulla, it's quite and very easy to approach as compared to the upper medulla. This when we open this one, just peeling this one, we directly will be at the level of you can say little bit retraction of the tonsils. You will be at the level of the lower part of the medulla, posterior surface of the medulla. So when you say this will be the posterior median sulcus, yes, please. Am I right? So this will be the posterior median sulcus. If we are going through, if you are suspecting that there is a lesion inside this one, now it's very easy to open this sulcus and now then we approach that lesion. But suppose that if the lesion is at the level of, you can say, the upper part of the medulla oblongata, now it is quite a little bit difficult. There is no any hard areas are there. Just you have to know and understand the normal anatomy. Then it will be quite easy for us to go and approach that one. This is which part of posterior fossa? Yes, please. This is
Obex?
Obex.
yes.
Sir.
Yes, excellent. It's obex. Okay. It's obex. So when we are going to the upper part of the medulla oblongata, Then we have to approach through with the help of which approach? Which approach?
Telovelar
Yes.
approach. Telovelar approach.
Telovelar approach.
Yeah,
Telovelar
Telovelar.
approach. Excellent. Telovelar approach. Excellent. Telovelar approach. Then upper part of the medulla oblongata, we can approach with the help of telovelar approach. What is the telovelar approach? We have to retract. We have to retract this tonsils bilaterally. When you are retracting the tonsils bilaterally, just anterior to this one and above this one, we can get first structure that you have to identify in telovelar approach. What structure will be? Yes. What structure you will identify? Yes, someone says pica. Someone is saying pica. Excellent. You have to identify the pica. You have to identify the pica, and you have to be careful about the pica if you're not going to disturb it. After that, pica, there will be the inferior medullary velum superiorly, because we have to work at the lower side of the fourth ventricle, below to the inferior medullary velum, not superior to this one. Why? Why not above the superior inferior medullary velum? Yes, please. Because the lower part of the roof of the fourth ventricle, or most of the cerebellum, it has non-functioning areas are there. That's why it's very important. When you're going to the floor of this one, just anterior to the pica, it is now there will be the junction that we call the TV junction, telovelar junction. T stand for T stand for Tela cord. Sorry, yes, please.
T stands for Telo.
Telo? What is Telo?
Telachoroidea. Telachoroidea.
Telachoroidea. T stands for telachoroidea, and V stands for
Fourth ventricle.
Inferior medullary velum.
Excellent. V for inferior medullary velum. So that's why we call it telovelar approach. The junction between the choroidea and the inferior medullary velum. It is just a thin layer structure. That when we will cut down it, we will enter into the fourth ventricle, and that's above to the superior part of the medulla oblongata. So this is the later on discussion. Just I told you that how we will have to approach when we are going superiorly. We will discuss in detail the superior part. So when you open the posterior part of this one, the posterior fossa, directly you will address the lower part of the medulla oblongata, and you can get access easily to the part this one on the posterior surface. Lateral surface has structures. This is the vertebral artery, and this, when we go above one, this will be the pica. Posteriorly, anteriorly there will be the pica. Later on structures, here will be the nerves, and you can see the superior part. The lower part has the 12th nerve, and above part, the upper part we have the 12th nerve, and lower part we have the 9th and 11th nerve. Okay. So yes, this is the lower part of the medulla. So this is the MRI of the patient. Anyone who can interpret of this MRI?
Yes, sir.
Yes, please.
So the on first image is axial section with contrast, T1 with contrast, and there is I cannot appreciate any lesion, and the other one is the coronal section with contrast, and there is some hypo intense lesion at the level of the yes, medulla, and the other is the sagittal section with T1 with contrast, and there is some lesion at the upper part of the medulla.
So these are the different patients you are saying?
So same patient.
So then why you said that this is the lower part of medulla, this is the above part of medulla? All at the lesions are at the lower part of the medulla, just at the site of the, just below the fourth ventricle. So this is the lesions, this is the hypo intense lesions. The surrounding is more hypointensities are there, very well circumscribed lesion is there on the lateral side of the medulla oblongata, this one on the right side. So what this lesion could be?
It could be a medulla.
From Abdullah is saying it is a cavernoma.
No, sir.
Yes, it's a cavernoma.
It is a medulloblastoma.
It's a medulloblastoma. So tiny lesion and lateral side rising from the and well circumscribed. There is no enhancing. It is possible that medulloblastoma will not enhance. At least so tiny lesion. Yes, Mustafa.
Yes, sir. No, sir. It shows patchy contrast enhancement.
So
and T2
shows no
intense. Yes, sir.
So then what this lesion could be?
Polycystic astrocytoma.
No. Abdullah is saying cavernoma. Abdullah, why cavernoma? Yes, please. Where is Abdullah? What is the radiology of cavernoma? How it appears?
Popcorn.
Yes, popcorn appearance on T2.
Why not hemangioblastoma?
Sorry?
Why not hemangioblastoma?
Hemangioblastoma.
Yeah.
Hemangioblastoma.
Yeah.
No, it's not hemangioblastoma. Hemangioblastoma, it is not so well circumscribed, and laterally on the lining, it shows no any, you can say, the hypointensities, and there should be most of the time there should be the mural nodule, and the solid part. This tumor, looks little bit solid component is there. There should be some enhancement when there is a solid part is there and mural nodule is there. And hemangioblastoma, most of the time it arises in the
cerebellar hemisphere.
Cerebellar hemispheres, not in this one. So yes, when we will to do, it is Dr. Ikra is saying that it is the meningioma. No, it's the cavernoma. You will see the T2 weighted is a well circumscribed, tiny, contrast, non-enhancing lesion surrounding. There is a hypointense more, so most likely it is a cavernoma. So what approach could be there? Just now we have discussed that lower part of the medulla, we can address the posterior suboccipital approach, and it's quite easy to address that one. So what approach could be there? And we have gone through just overview and outlines. We have discussed that the details of the approach. So what approach you will do? Yes, please. It is just lateral margin of the medulla oblongata on right side. So what approach you can do?
So through anterolateral sulcus?
Anterolateral sulcus. Why you are saying sulcus? Anterolateral sulcus? Yes, you are right. Good, anterolateral sulcus. So when you are going through the anterolateral sulcus, you will go through this suboccipital approach or far lateral approach. You're right. You will go for the anterolateral sulcus, but far lateral approach or suboccipital approach?
The far lateral approach.
Far lateral approach. Okay. So this lesion is at the level of the posterior lateral side or anterior lateral side?
So this is on posterior lateral side. No?
This is on the posterior lateral side. So for lateral approach, most of the time it is for
Interior.
anterior lateral approach. The lesion is anterior and laterally there, so it's very difficult. So you can the point that you can go through the standard suboccipital approach by this tiny lesion in the same way. Just you have to retract on the ipsilateral side more. The tonsil retraction will be more, and then you can get this lesion very easily by through the approach of the anterolateral sulcus. So now, what kind of a lesion this one? Yes, please. What kind of a lesion this one?
Like
The cavernoma.
blastoma.
Now there should be no doubt. How many people are saying that it is a cavernoma, and those saying just comment on this one, then I will see that how many say that. So this is not a, you can say the hemangioblastima, this is not meningioma, this is not glioma, it's a cavernoma.
I just want to make a single point. All of you people, especially the ones who are regular listeners, you people need to go back to the recordings and go through the radiology very quickly, because we have discussed radiologies of all these DDs that you were suggesting in a very thorough manner. So I am quite surprised that you thought that this was a medullo or a hemangioblastoma or a pilocytic astrocytoma. I expected better.
Why I don't know that why they are so confused interpreting the radiology. They shouldn't be confused too much like this, that. So it's a cavernoma. Where is my screen? So just when you are saying that it's just a posterior lateral part, just at the that are the border of, you can say, the medulla oblongata, with the standard suboccipital approach, you can easily get access to that tiny lesions. No need for go to this very extended far lateral approach. Far lateral approach is quite difficult and it has a lot of need some expertise. So simply you can get access to this suboccipital approach. If it is a lower medulla, then it will be easy for us to get the lateral side and anterolateral sulcal dissection and opening of the medulla and removing of resection of whole cavernoma. Cavernoma can be resected completely. We can resect it by these trajectories. Should we continue? I think I've got too much time.
Yes, it has been 15 minutes. I think we need to conclude today's session and continue this tomorrow, if that is okay with you.
So it's okay. Tomorrow, I have to complete the far lateral approach and bit about the Telovelar approach and the posterior approach, another one that is the transpetrosal approach. So I will complete, inshallah, these three is one. Because the Telovelar approach, they have bit idea. It will be easy to conclude it, and far lateral will take some time, and far lateral, when we conclude the far lateral, then petrosal will be easy. So tomorrow, inshallah, we'll do the far lateral approach and the petrosal approach, anterior petrosal approach, transpetrosectomy, anterior, that how will we approach the anterolateral lesions, superior side. So up to here, any question you will put onto the WhatsApp group, then I will try to answer that one.
Dr. Tizas, kindly elaborate the safe triangles once again, please.
Sorry?
Kindly elaborate the safe triangles once again, please.
She means the safe
Safe,
surgical zones. Yeah, the safe surgical
Yeah,
zones.
safe surgical zones. Safe surgical zones are quite easy. When we are entering the medulla oblongata, then we have the 4 zones to enter only. 4 zones. One in the
Hmm.
anterior side that we call the anterior median sulcus. Anteriorly, when we are going to the anteriorly inside the medulla, we have to enter through the anterior median sulcus. When you are approaching the posterior side and your target is midline, the lesion at the midline, at the middle area of the medulla oblongata, posteriorly we can open the posterior median sulcus, the fissure you can say. When you are saying the laterally, like this, the last one there is the cavernomas there, we have the anterolateral sulcus. When we are going to the anterolaterally, posteriorly, we can go to the posterolateral sulcus. These are the safe zones, and that anterolateral sulcus, that is also it is known as you can say we can say that approach is the trans-olivary approach because the olivary nucleus is there. That's why the tract is there. That we also call the trans-olivary approach. So these are the safe entry zones inside the medulla oblongata.
Thank you so
Clear
much.
now?
Yes,
Okay, welcome.
thank you.
I'll reshare the recordings to the previous lectures of Medulla series, where we have covered the surgical anatomy and the safe zones very thoroughly. So you guys can go back and take a look at that playlist. I'll also reshare the PDF links because there was this entire summary of the sessions so that anybody who has missed on it would be able to review it and would be better oriented in the next session, inshallah. So,
Thank
Dr.
you,
Atzaz, is that a wrap from your side?
Dr. Kamal.
Your voice is breaking.
I'm saying thank you so much. Despite of your busy schedule, you are also here.
No, that's completely fine. This was a prior commitment. So that's a wrap, everyone. I am going to share the link to the live stream.
Thank you so much.
And I'm also going to share the previous links as well. Thank you so much, everyone. Thank you so much for joining.
Tomorrow will continue. Tomorrow session will be a little bit heavy, so and little bit maybe some boring because the lateral approach is bit tricky and petrosal approach is bit tricky. But if someone has the good anatomy background knowledge, then it will be quite easy to understand for us that how we are approaching these kind of lesions. Thank you so much.
Okay, everyone, that's a wrap.